So, good morning all dignitaries of the dais and my colleagues in this room. So, we are going to present a case of a 2-year-old female child with jaundice and pruritus. We are from the Department of Hepato-Pancreato-Biliary Surgery and Liver Transplantation, wherein we have got 2 professors and 1 assistant professor. Department technically had started in 2018, where we were doing transplant as well, apart from the HPB work, and the MCH program was started in 2022. Our first batch has already appeared for the exam, and it's now technically, with the results declared, he has passed, and that becomes an outgoing batch. The first batch has officially cleared from Mahatma Gandhi of MCH HPB surgery. Now, when we talk of HPB surgery, what involves? It's surgery of liver, gallbladder, bile duct, pancreas. It's not only liver transplant, as many would wrongly assume. So we do a lot of surgeries apart from liver transplant. We do pancreatic surgeries, which is not only limited to Whipple's. We do a lot of cancers, CAGBs, liver cancer, pancreatic cancer. We do get patients referred to our center for bile duct injury. We do help out our colleague ancillary departments, wherein they have to deal with tumors around the inferior vena cava, like RCC or large adrenal tumors. We also do advanced laparoscopic, robotic and complex open surgeries, as I said, in all age groups. Fortunately, the faculty has been invited at various national and international forums, be it European Society, be it Asia Pacific Hepato-Pancreato-Biliary Society, or a Korean Endoscopic Laparoscopic Robotic Surgery Society. In fact, in some of the surgical gastro conferences also, we do have invited talks wherein we go and talk, give our lectures. We were also invited in a pediatric HPB masterclass, where we did train pediatric surgeons the nuances of HPB surgery, because the exposure for a pediatric surgeon in HPB specialty is relatively lesser as compared to what we deal in HPB surgery routinely. Coming to our publication, it is not only going out and giving talks, but what we publish is what gives recognition as well. So we have been doing, so this is just one of our students had done comparing rule loop and a single loop post Whipple's and what is the outcome. We have also evaluated fibroscan, what is the value of it, whether it can assess steatosis in living donors. We have also assessed our work where it was a public-private partnership offering them liver transplantation at a no out-of-pocket cost. Pancreas transplant, again we have written a brief overview about it. Management of hilar cholangiocarcinoma. Hepatoblastoma, again we have been performing, so we have got a large series of hepatoblastomas. We have also been part of the LTSI guidelines for liver transplantation during COVID times, and we have been publishing various other material related to liver transplantation. Coming to the other academic activities we have been doing at the institute is we have celebrated Indian Organ Donation Day. We have conducted an organ retrieval masterclass for various consultants across the state and trained them for the retrieval procedure. We have celebrated the Global Fatty Liver Day. We also were fortunate enough to start the Liver Summit Conference in association with the IHPBA, that is the International Hepato-Pancreato-Biliary Association, the Indian chapter, where we did a midterm meeting last year, and we had a good participation with faculties coming from here, India, and international faculties also taking part in it. This is some of the glimpses of the organ retrieval cadaveric course which we did last year, where the candidates had come across the state who were being trained on the cadaver, the method of retrieval of liver, kidney and other abdominal organs. Again, it was not only limited to only publication and doing activities, but what your resident actually, the recognition of the teacher comes based on what the student performs, and this is some of our trainees. We do not differentiate. We have a department which is technically a center for digestive sciences, and we do not differentiate whether the student is doing MCH in GI surgery or MCH in HPB surgery. It is a combined department. So both these students have had national and international presentations. Herschel and Millen both are technically have completed their MCH GI surgery. They have received award in their presentation in liver category, pancreas paper, IHPBA, the Society of Laparoscopic Liver Surgeons Society in Korea. So they have been doing a lot of work in HPB surgeries as well, where they have received their award. Another residents who are, Dr. Manmohan was the first candidate who has passed his MCH in HPB surgery. He has presented his data on the paper which he was working, which has been now published. Dr. Raghuram Nelluri, he is the second year MCH HPB student who recently went, apart from presenting his work in the national conferences, he was also invited as a young investigator award paper in the recently APASL conference, where he went and he spoke about the work we were doing, scientific work we are doing in the department. So this is a photograph which he had just sent to us from after attending the APASL. Dr. Saurabh is also completed his DM organ transplant anesthesia, was also doing some of the work on paper in association with us and has received his award. Dr. Hrishikesh and Rajiv, again they have been doing a lot of work in liver related work, where they are presenting in these conferences and have been receiving awards in the last year conference. The upcoming meetings where we have International Liver Transplant Society, so two of our residents, Hrishikesh and Akshat, both are MCH GI surgery students, both have got presentation in the International Liver Transplant Society in the meeting which is upcoming in the month of May in Singapore. We at the institute also, since we are completing 25 or a silver jubilee of our institute, we are conducting many conferences at our institute. So one of such national conferences, Indian Society of Organ Transplantation, which will be conducted in October, being held by our department. So it will be conducted in Novotel and in the Intercontinental Hotel. And also we will be conducting the national meeting of Indian chapter of IHPBA, that is International Hepato-Pancreato-Biliary Association, in the month of February 2026. After doing all this, we still do have some time to perform some surgeries. So we have done about more than 350 hepatic surgeries, 130 plus liver transplant since in last couple of years, more than 650 biliary surgeries, 200 plus pancreatic surgeries. This was the graph of only liver transplantation, because the program, though it started way back in 2018, when I had also officially been visiting this institute. COVID, the program had actually plummeted down, but since then it has really picked up, and this year it's only a quarter of the year has passed and we have done about 12 transplants this year as well. Fortunately, God has been very kind, where we have been able to perform many firsts of the state of Rajasthan. So first, be it cadaveric liver transplant, living donor, LDLT for acute liver failure, LDLT for HCC, pediatric liver transplant, or pediatric for liver transplant for ALF, combined liver and kidney transplants, dual lobe transplant, and recently we were also fortunate to perform the first ABO blood group incompatible living donor liver transplant in the state of Rajasthan. So this is the institute's vision, where we have combined departments. Hopefully it will be housed together in the new wing which is coming up, where all these four departments will function cohesively together as the Center for Digestive Sciences, and I hope together all the four our departments will be able to grow and push the institute's name to a different level as well. So I would like to now invite Dr. Hrishikesh, who are second year MCH student, to take us through the case, please.
Good morning. I'll be starting off with the case. We have a 2-year-old female child with complaints of excessive crying and which was inconsolable for past 15 months. She also had generalized itching which was present all over the body, and yellowish discoloration of eyes for last 1 year. She also was unable to gain weight and had on and off loose stools with associated abdominal distension. All her symptoms began at the age of 9 months. She has itching for past 1 year, and it was noticed by mother since she had scratch marks seen all over the body, including the torso and the limbs. And her mother also noticed yellowish discoloration of sclera for past 1 year, which was initially noted in the eyes and progressed and became generalized. This jaundice was also associated with the clay-colored stools. She also has history of chronic diarrhea, which was intermittent, which was on and off, and she was passing water consistency of stools, and stools were greasy and foul-smelling in nature. And this diarrhea was every time managed in a local hospital by oral medications, which relieved the diarrhea. She also had associated diffuse abdominal distension, which was insidious in onset and progressive in nature. She had no history of fever, cough, shortness of breath, vomiting or hematemesis. She had no history of melena or hematochezia, no any history of any surgeries during the neonatal or early infancy period, and she had no history of seizures and no history of loss of consciousness, any earlier history of blood transfusion, any drug or toxin ingestion. So moving on, there was no significant past history, and her antenatal, natal or the postnatal history, she was delivered by, in full term and hospital delivery, normal vaginal delivery, and she had no NICU stay during her neonatal period, and she is completely immunized as per national immunization program for her age. Moving on to her developmental milestones, overall, when comparing all the 4 domains of the development, main lagging was the gross motor milestone and also the social milestone, with cumulative development quotient of 70%. She had no significant family history. She was born on a non-consanguineous marriage, and she had no siblings. As per her dietary recall history, her calorie and protein deficit was around with an average of 15%. So, according to her age and the total calorie intake was adequate. Still, she wasn't able to gain weight, so it might point out towards a malabsorption syndrome, and since it was also associated with jaundice, so it may be due to a biliary related disease. So to summarize, she is a 2-year-old female child with pruritus associated with clay-colored stools, progressive jaundice, abdominal distension, and chronic diarrhea. So what might be the possibilities? Anyone would like to answer this? Okay, to summarize the causes of mainly neonatal and early infancy.
Wait. Which department? When does biliary atresia manifest?
Sir,
when did the jaundice start in this child?
sir, later in the post-infancy.
9 months.
Yes, sir, 9 months.
It is, please correct me if I am wrong, it is virtually impossible to have biliary atresia if the
No,
jaundice
sir.
starting at 9 months.
No, sir.
So you should not have said, being a pediatrics resident, you should not have said biliary atresia as the first diagnosis in this case. I don't think, if there is no jaundice for 9 months, as far as I know, biliary atresia is ruled out.
So with the history, we have categorized the jaundice in the neonatal and early infancy towards the obstruction. As sir has pointed out, biliary atresia is unlikely, And other causes of obstruction might be a biliary tumors, neonatal sclerosing cholangitis, chronic helminthic infection, or a choledochal cyst. Genetic and metabolic disorders, including inherited disorders like Alagille syndrome, cystic fibrosis, and progressive familial intrahepatic cholestasis, and inborn error of metabolism, including carbohydrate, lipid, and fat metabolism. And it can be due to infection, which can be due to viral, bacterial, protozoal, and also helminthic infection. And can less likely, but can be due to toxin. However, we have ruled them out through the history. And other miscellaneous causes including idiopathic neonatal hepatitis, congenital portosystemic shunt, and along with that autoimmune hepatitis. So moving on to her general physical examination, she is a conscious, alert, and playful child, examined in supine position in well-lit conditions. Her vitals were normal. Her height was 68 centimeter and her weight was 6.9 kilos. Both were under below the third centile. As we can see, both the height or length is below third centile and also the weight is below third centile. And head circumference is normal and mid-arm circumference is on the lower side. She had pallor and icterus. However, she had no history of clubbing, no cyanosis, no lymphadenopathy, and no generalized edema. Moving on to her systemic examination, main system is her abdomen. On inspection, abdomen was distended, as we can see in the figure, and with central umbilicus and stretched out veins can be noted on the abdomen. However, there are no scars or sinuses noted. And on palpation, on superficial palpation, no normal temperature and no tenderness was found. The liver was palpable 4 cm below the costal margin, and on percussion, dull note is noted in all quadrants, and fluid thrill was present. Upper border of the liver was in the 4th intercostal space in the right midclavicular line, and liver span was around 12 cm. At 2 years of age, the normal liver span is around 7 to 8 centimeters. So hepatomegaly was found in this patient. And on auscultation, bowel sounds were normal and no added sounds were heard. Moving on to our systemic examination, our cardiovascular, respiratory system, and CNS, everything was within normal limit. And however, there was delayed developmental milestone, mainly in the gross motor and social domains, as described earlier. So among this, the main these two can be ruled out, since these two are less likely in this case and others are still kept. On further investigating the patient, we found anemia on complete blood counts, and her RFTs and renal function were normal along with her electrolytes. And on her LFTs, she had conjugated hyperbilirubinemia, normal liver enzymes, and raised alkaline phosphatase. She also had low albumin, might point towards malnutrition, and her vital markers were negative. On abdominal sonography, only 2 positive findings were heterogeneously enlarged liver and free fluid in the abdomen. And on similarly, a triple phase CT abdomen was done, which revealed hepatomegaly with ascites. However, her portal vein diameter, according to her age, was normal and spleen was not enlarged. So to summarize, we have a 2-year-old female child with history of pruritus, progressive jaundice, and clay-colored stool associated. On examination, she had icterus, ascites, and hepatomegaly. And on further investigating the patient, she had conjugated hyperbilirubinemia with raised alkaline phosphatase and hypoalbuminemia, and also anemia. On radiology, it was evident that she had non-cirrhotic liver with hepatomegaly and normal spleen. I would call Dr. Isha to further work up the patient from Department of Pediatrics.
I will discuss this case further based on the history and investigation. The following differentials were considered. In infectious causes, viral hepatitis was ruled out as the serology was negative. In autoimmune causes, for autoimmune hepatitis, Autoimmune antibodies were done including ANA, smooth muscle antibody, perinuclear antinuclear cytoplasmic antibody, liver kidney microsomal antibody and total IgG, which came out to within the normal range with total IgG in the normal limit, ruling out the autoimmune hepatitis. For structural and obstructive causes on the history, the age of presentation was not likely and there was a normal HIDA scan ruling out the structural and obstructive causes. In metabolic and genetic causes, galactosemia, tyrosinemia type 1, glycogen storage type 4, cystic fibrosis, PFIC type 1, 2, 3 and alpha-trypsin 1 deficiency were kept as a possible differentials. Galactosemia was ruled out as there was no history of feed intolerance, hypotonia, hypoglycemia or evidence of cataract in our patient. Cystic fibrosis was ruled out on the basis of the history as there was no history of recurrent respiratory infection or chronic cough. For PFIC, tyrosinemia and glycogen storage type 4 and alpha-1 antitrypsin deficiency, further genetic workup and liver biopsy was planned. I would like to invite Dr. Khushi to take the case further.
Good morning everyone. I'll discuss about the histopathological aspect of this case. So before proceeding further, I briefly discuss about the normal histology of liver. The image 1 shows central vein which is surrounded by the portal tracts showing no fibrosis. Image 2 shows portal triad and its contents, that is the portal vein, the bile duct and the hepatic arteriole. So I'll shortly tell how we assess the staging extent of fibrosis in liver biopsies as we usually do. So there are various staging systems for fibrosis in liver, but the most commonly used worldwide and also preferred by the clinicians is the modified Isha staging system. According to this stage, liver biopsies are categorized into six stages ranging from F0, that is no fibrosis, which further progresses like shown in the image, to F6, that is cirrhosis. Moving on with the pathological aspect of the case, we received two linear tissue cores, and on microscopic examination as seen in image 1, mild lobular disarray was observed with increased fibrosis in the portal tract with periportal extension and thin fibrous septa formation. As seen in image 2, mild canalicular cholestasis was also seen and there was no significant lobular inflammation. On mesostrichrome stain on the same biopsy, collagen deposition is highlighted in blue against the red hepatocytes. Before concluding, I'd like to show representative images from F3 and compare with F6 just in terms of the extent of fibrosis in both the cases. So as seen in image 1 and 2, fibrosis in F3 is seen as thin fibrous bands connecting the two portal tracts, in contrast to fibrosis in cirrhosis where the fibrous bands are more thick and they surround the regenerating nodules. Thank you for my attention. I'd now like to call Dr. Isha to take the case further.
The genetic report came after 45 days, suggestive of familial intrahepatic cholestasis type 1. So our final diagnosis is progressive familial intrahepatic cholestasis type 1. Progressive familial intrahepatic cholestasis is a rare, autosomal recessive inherited liver disease characterized by impaired bile flow leading to progressive liver damage. The incidence of PFIC in world is 1 in 1 lakh and in India is 1 in 50,000. It manifests in infancy or early childhood. It may progress to cirrhosis and liver failure. PFIC, there are 3 main types based on the genetic defects. This diagram illustrates the molecular basis of PFIC and it highlights the key transport protein involved in the bile formation in the bile canaliculi. The ATP8B1 is responsible for bile flow and its mutation in PFIC leads to bile flow impairment and cholestasis. The ABCB11 is responsible for actively secreting bile salts into the canaliculi. and its mutation causes severe cholestasis and bile salt accumulation. The ABCB4 is responsible for transporting the bile, and its mutation leads to PFIC3. All PFIC type 1, type 2 and 3 are autosomal recessive. There is progressive cholestasis with diarrhea, steatorrhea, growth failure and severe pruritus. Based upon the biochemical features, there is normal serum levels of GGT in PFIC1 and PFIC2, and there is elevated GGT in PFIC3. Now, I would like to call upon stage Dr. Devendra to take the case further.
Good morning, everyone. With the discussion till now, we have a case of progressive familial intrahepatic cholestasis type 1 confirmed with the genetic testing. So, I will discuss the normal physiology, the pathophysiology and the management of PFIC. So, this diagram here shows the normal enterohepatic circulation of bile salts. The both primary and secondary bile salts after getting secreted from the liver through the biliary system are transported to the intestine, and from the terminal ileum they are reabsorbed and through the hepatic portal system are transferred to the liver. And this enterohepatic circulation is so efficient that more than 90% of the bile salts which are secreted into the intestine are they are again recirculated to the liver. Now, what happens in PFIC is that the normal canalicular bile salt transport is hindered. So, the bile salts instead of getting secreted into the biliary system, they are absorbed into the serum, and that leads to the pruritus and the symptoms of PFIC. So, why we need to disrupt this enterohepatic circulation? Because disruption of the enterohepatic circulation will reduce the hepatic bile acid overload, as the 95% of the bile salts which are getting reabsorbed, that will be blocked. This will elevate the cholestasis and in turn will decrease the liver damage and fibrosis, and will improve the symptoms due to the excess serum bile salts. So, this was a 2-year-old 70 kg female child, 7 kg female child. This was managed initially with medical management. She was given cholecalcistyramine, which again reduces the intestinal absorption of the bile salts. Rifampicin, ursodiol and tablet drops hydroxygen, which again reduces the pruritus. As there is decreased bile salts and this leads to fat soluble vitamin deficiency, so the she was replenished with vitamins. Now, after the medical management, we have the two types of surgical management for PFIC. One is non-transplant surgical management and the other is of course liver transplant. So, in non-transplant surgical management, we basically block the enterohepatic circulation. So, the different ways to block this enterohepatic circulation is putting a tube into the bile duct or draining directly the bile from the gallbladder, either to the exterior or into the intestine. And the third is diverting the flow from the ileum, as ileum is the distal ileum is the main site for the absorption. So, the aim in PFIC through surgery is to manage the complications of cholestasis and again the management of the end-stage liver disease. The symptoms and the status of liver, this decides the type of surgical intervention, as in this patient importantly the pruritus, intractable pruritus was the main indication, and in liver there was no feature suggestive of cirrhosis. So, non-transplant surgical management was done, and the non-transplant surgical management, this consists of three types of biliary drainage. The first one shown is the partial external biliary drainage, where a isolated jejunal loop is used to drain the bile from gallbladder to the exterior, creating a stoma. This was done in a different patient at our institute. The type B, that is partial internal biliary drainage, this was performed in this patient which we are discussing. In this particular patient, we performed isolated through loop drainage from gallbladder to the colon. And the third type is where the terminal ileum is excluded by anastomosing the 30 centimeter proximal ileum to the cecum. So now I have a video presentation of the surgical procedure. Okay. So we have given a right subcostal incision. This is the transverse colon being splayed, and now we are tracing the duodenojejunal flexure. Now from the duodenojejunal flexure, we create an isolated roux limb based on the jejunal arcade. This is the isolated jejunal loop being created. This is the isolated loop. Now this is through the retrocolic window. We took the loop to the supracolic compartment, and now the cholecystojejunal anastomosis is being performed. The proximal end of the isolated jejunal loop is anastomosed to the gallbladder. The gallbladder is opened, bile is suctioned, and now the anastomosis is being performed. So the surgeon is standing on the right side of the patient. After completing the cholecystojejunal anastomosis, then the distal end of the isolated roux limb is anastomosed to the colon. This is the jejunocolic anastomosis being performed. So the colon is being opened here. And the distal limb is then anastomosed to the transverse colon. This is the completed jejunocolic anastomosis. To establish the continuity of the intestine, jejunojejunal anastomosis is then performed. So this completes the procedure. So basically 3 anastomoses are performed. One is the cholecystojejunal, then other is the jejunocolic, and finally the jejunojejunal. The duration of surgery was approximately 3 hours. It was uneventful intraoperatively. Postoperatively, patient was shifted to PICU for observation and postoperative care. Her symptoms of itching started reducing in the immediate postoperative period, and she was discharged comfortably on the day 7. At follow-up, patient is pruritus free at 6 months of follow-up, and she is gaining weight and passing around 3 to 4 solid yellow stools per day. This is a small video clip. So the child is free of pruritus, and he is gaining the developmental milestone according to the age. So the other management modality is transplant. When the transplant is indicated, it is regardless of the genotype or phenotype, that is may be required in type 1, 2 or 3, and the indication is in patients who develop end-stage liver disease or pruritus, which is even refractory to a surgical drainage procedure, and in case of evidence of hepatocellular carcinoma, which is more common in type 2 PFIC. So now why this case?
Before that, two things you will have to explain. One is that since we have disturbed the normal physiology, is it going to have any absorption and nutritional side effects? Because now there is no or very little bile reaching the
Yes, sir. As the bile salts are not reaching into the terminal ileum, so there may be there will be fat malabsorption and the vitamin deficiency, fat soluble vitamin deficiency, that we will have to supplement.
So are there reports of long-term outcomes of this procedure? What happens to these children?
Sir, in the literature, there has been said that when performed in early childhood, this and when the patient has not developed cirrhosis, this act and like for 2 to 3 decades, the patient may not require liver transplant.
And second, since this is a genetic disorder, even if you do transplant, will the transplanted liver also develop the same problem?
That I'm not.
I think the genes are present in the liver that has been removed. And when you give another liver which has will have normal bile acid secretion and genes, in fact that will be a total metabolic as well as physiological correction of the abnormality.
And yeah, please. It was another question.
So this procedure is technically being performed as a bridge, because early in childhood at 2 years you do not want to go ahead and perform liver transplantation. One is for the technical reason, because the vessels are too small, the child will continue growing. You would prefer that if you are able to buy some time till the child reaches a teenage or an adulthood, and then if at all required. So there are two things we are doing here. Is one, by this we are delaying the progression of this disease, because it's a progressive familial disorder which we cannot change it. Then the second point is we are trying to avoid the damage to the native liver. If you do it at an early stage, then the damage to the native liver is avoided. We postpone it as much as possible, maybe 2 decades, 3 decades down the line, whenever the damage becomes so significant that at that stage if you perform a liver transplantation, the patient acceptance is much better, compliance is much better, and you get a longevity of life as well. So that is the reason why this procedure is being performed at an early stage.
So basically biliary diversion in a child which is age 2 years, as sir correctly mentioned, the child needs some time to gain some weight to increase the durability, plus the donorship also matters in this case. The child is weighing only 7-8 kg. We need at least a child of 10 kg and above to go through this liver transplant procedure. Plus, as Dr. Devendra correctly mentioned, that nutrition rehabilitation is very, very important after this biliary diversion. Otherwise, the child will land up in acute condition again in the ICUs, and we need to manage that particular child, and child may again go into acute ascites plus the vitamin malabsorption.
So the early liver failure which the child had, I think the ascites and the hypoalbuminemia were indicators of early liver failure. This will reverse. This will correct itself.
Plus the initial management which we have done medically before the surgery was very, very important in preparation to do this surgery. Otherwise the child would not have gone through the surgery. And initially the ascites was drained, as Dr. Kapoor sir clearly mentioned, that the before biopsy ascites should be drained and was drained in this case, and post the surgery the child was free from ascites for quite some time, and the child is in our follow-up and is doing well.
And suppose the parents want another child, then in utero diagnosis of the same genetic malformation is advised, like genetic counseling should be offered?
Sir, so we had involved the geneticist in this, and unfortunately Aditi couldn't be here with us today due to some personal work. But otherwise, yes, so when they go in for a second child, they need to be counseled from the genetic point of view.
So coming on to why this case was selected. So we want to emphasize that other than liver transplant, in the HPB department, we are performing other complex hepatobiliary surgeries, both in adults as well as pediatric patients. And in this particular case, early diagnosis is can avoid liver transplant for a long time. And if we diagnose it early, then only we have the option of the non-transplant surgical management. And also our department is experienced in pediatric hepato-pancreato-biliary surgeries like hepatoblastoma with good outcomes. Also the spectrum of such disease, like if not recognized early, then the child will develop cirrhosis, or a case of PFIC3, if not recognized early, they present with rapid cirrhosis, which will leave us only liver transplant as the modality of management. So this is a picture of the child in the post-operative follow-up, and this was to emphasize the PFIC3, which presents directly with chronic liver disease, decompensated and with portal hypertension. And this was a 12-year female patient, and she underwent living donor liver transplant as the liver was already cirrhotic, and her post-operative outcome was uneventful. She was discharged on post-op day 14, and on a 1.5 year follow-up she is also doing well. I would like to thank the administration and management of MGUMST and all the supportive departments who helped us to manage this patient and to prepare this presentation. Thank you.